to order, and I want to welcome all of you to the Tahoe Forest Hospital regular board meeting for August 2021. And could I have General Counsel read us out of closed session?
Certainly. The board considered 8 items in closed session this evening. There was no reportable action on items 5.1 through 5.6. As to item 5.7, approval of closed session minutes, those were approved on a 4-0 vote. And as for medical staff credentialing, those were also approved on a 4-0 vote.
Thank you so much. Any deletions, corrections to the posted agenda? The one that was covered in our very beginning of the open session was the financial report that's included in the consent calendar is for July and not June. So that'll be reflected in our minutes. Any other deletions or corrections? Okay, hearing none, we'll move on to item 10, which is audience input. And this is an opportunity for anybody in our audience to speak on anything not on the agenda. There is a time limitation. And if anybody wants to speak before you start, I'll tell you what those limitations are. Is there anyone that would like to address the board on something not on the agenda? I see a hand raised.
Yes.
And so before I let them speak, I want to let you know what the guidelines are, is that you have 3 minutes to address your comments to the board. If you'll begin by stating your name, and also that the board under the Brown Act cannot discuss the comments that you make. We can acknowledge them, but we cannot discuss them. So I see a hand raised, and this is Stephanie Bacon. Are there any other hands that want to speak? Okay, Stephanie.
Hello again. I will be clear in saying that Mr. Weiss asked me never to talk again about the billing issue from the spring. So tonight I'm here to just talk about a more broad issue. I'll do my best to discuss this issue in 3 minutes, but I will tell you it is a very complex term that I'd like to bring to your attention. I'd like for you guys to think for a moment about the concept of hegemony. It's a concept that not everybody's familiar with. I certainly wasn't until I was studying for my master's degree. I'm going to read you the dictionary definition, and I hope you look into it more. Again, the word is hegemony. It is dominance of one social group over another, such that the ruling group acquires some degree of consent from the subordinate, as opposed to dominance by purely force. And the reason I bring this to your attention is because it's such a tricky concept. It's the almost imperceptible dominance of one class over another. And it's often ignored by most people because it's not by force. It's dominance by those in power using subtle acts of denial and microaggressions that are not obvious outwardly. They don't catch media attention. It's not easy to see. As members of the board and Tahoe Forest leadership team, you're in a position of power. People like me are subject to your power, your choices, and your actions. The tools of hegemony, this concept I want you to be aware of, how the people in power engage it, are by using denial of the power structure, saying, no, we have a democratic process, denial of the reality of problems of the subordinate class that the subordinate class experiences, condescension, meaning talking down to you don't know anything when someone brings up a point, using exhaustion, hoping people get tired of fighting back, retaliation, and fear. Hegemony is what has allowed racism, classism, misogyny, and homophobia to persist in our lives despite our best efforts to end these problems. My experience with the Tahoe Forest leadership has included all of the tools of hegemony. And for that reason, I'm here tonight. I thought Tahoe Forest was better than that. I thought the leadership would respectfully engage with its community, but it instead continues to deny that there's a problem and therefore continues to play a huge role in the problem's persistence. Thank you.
Okay, any other comments from our audience?
I think we have a couple more hands.
I see two more hands.
Okay, so we have Kenny. Kenny, are you there? You're on mute. Okay, well, while we're waiting for Kenny, we'll go to Lynn McKechnie.
Okay, I'm hoping you're able to hear me. My
We
name is
are.
Lynn McKechnie. I live in Sierraville, but I lived in Truckee for almost 30 years. I actually worked at Tahoe Forest Hospital for like 17 years before I became a teacher. I'm here because there's an issue that I need to address that actually brought my daughter, who is Stephanie Bacon, to you, which is the concern about affordable health care at Tahoe Forest Hospital and in the community of Truckee, in the state of California, and in the United States in general. Okay. Tahoe Forest Hospital here is to provide a service to every member of its community. It is a nonprofit hospital because the need for its existence is humanitarian. And that should be the first and most pressing vision of the hospital. That brings us to how to provide that service in a manner that allows access to everyone. Pricing of that service must be made effective to maintain the service, but always with the key vision in mind. And that means keeping a focus on the ability of those least able to pay for those services. Is the care consistent and reliable? And the pricing must always reflect the humanitarian goal. Not always, as I've seen, as I researched into the practices of Tahoe Forest Hospital. What stood out in my study of the Tahoe Forest Hospital was a designation of a job focused on marketing. Really, is there a need to compete in a humanitarian goal if that is your key reason for being? Okay. I see an attempt to compete like a retail business would rather than affordability for vulnerable community members. So let's talk about pricing, about what we can change versus about what we should charge, about what we can charge.
Lynn, I'm going to have to cut you. The 3 minutes is up on your addressing. And I do want to say to both of our speakers, as that the hospital is doing its very best to enable access and quality care to everyone who comes and asks for it in our district. So I'll move on to pixel number 2. You're up next.
Sorry, this is Kenny, and I'm just having trouble with my different devices.
Okay, are you still pixel number 2?
Yes.
Okay,
Can you hear me?
yes, we can.
Okay. So I am here because I have been having continued billing issues with the Tahoe Forest Hospital. And I would like some to understand how I can get better estimates from the hospital for billing. In May, I had 47 blood tests that need to be done and asked for an estimate, which I was given on May 13th. That estimate said I owed the hospital $636.37. When I showed up to the hospital a couple weeks later to get those blood tests, they had no record of that estimate. And they did another estimate for me, and that was $638.32. So approximately just under $2 difference. I had the blood test done on June 10th. And then I noticed in my chart recently that I had another bill due, and I paid in full on June 10th when I had the blood test done. And my new bill is over $1,000 in addition to that. And the estimate that my insurance was billed the first time was $3,715. And it's now saying that my insurance is billed $9,043 for these same tests. So my question is, how can patients get accurate estimates for this work? I did all I could to try to get this done and understand the costs ahead of time, but this was significantly off. And so my bill is currently $1,000.56 over the $638 that I was quoted originally for, to me, blood tests that seems like they should be almost like a menu that you order at a restaurant, like nothing out of the ordinary besides what is known and what is being done ahead of time. So that is my question. How can we get accurate estimates? And what can patients do to correct the bills? Because even though I have called, sent messages via my chart and talked to 2 people on the phone, none of this has been corrected, and I have not been even given the credit for the $638.32 that I paid originally.
All right, Kenny, if you could leave your name and your email or a telephone number, we'll have someone who can give you some further information and follow up on you. Can you do that for us, please?
Thank you.
Thank you. Okay, I have Scott with your hand raised.
Good evening. My name is Scott Rusich. I'm a local Truckee resident, and I would like to defer my time back to Lynn McKechnie so she can finish her comment.
No, we're not going to allow that.
Is there a reason? Is there a procedural reason or policy for that?
David?
Yeah, that is at the discretion of the chair, and we've got a 3-minute time limit per speaker. This is,
And I am requesting to defer my 3-minute time limit to Ms. McKechnie.
if you have something you'd like to say for 3 minutes, we'd be happy to hear it.
I would just like her to take my time and use the opportunity to finish what her comment was.
And unfortunately, that's not the decision here. So
Yeah. And,
Okay, thank you for your consideration.
If Ms. McKechnie would like to put it in writing to us, we'll try to get back to her if we can. And we do have a full agenda ahead of us. So any other comments? Okay, then we'll move on to item 11, which is input from our Employees Association. Do we have anybody from our Employees Association that can tell us anything? I don't see a hand. Okay, so then we'll move on to acknowledgements, and we have our Chief Human Resource Officer, Alex McLennan, to give us our acknowledgement for the Employee of the Month.
Thank you. Yes, and I am the one that has the honor of announcing that Mason Power, Administrative Assistant in our Wellness Neighborhood, is our August 2021 Employee of the Month. And I've got a few things that people have said about her here. Mason has been with the Tahoe Forest Health System since September of 2019. She is always cheerful and makes others feel respected. Mason is a pleasure to work with. She's an amazing asset to the Wellness Neighborhood. And I think Mason said she was not able to come tonight, but just a huge round of applause for Mason, who's been stepping it up for us and taking on roles outside of her own to help us through in the quality department and reporting and other things like that. Mason's really stepped up. So huge shout out to Mason. Thank you.
Congratulations, Mason, and thank you for all that you do to make our organization the great organization that it is. We have Dr. Lane, who's going to go over the Medical Executive Committee meeting consent agenda. And I just want to let you know, I know there's a whole list of policies and procedures that he is going to ask us for approval of. I just want you to know that all of these policies have gone through many layers of approval, and it's not just the med staff sending them to us. So again, it's a process that we do for all of our policies. And he is just bringing them now after they've gone through so many other levels of approval. So with that, Dr. Lane, I'm going to turn it over to you.
Thank you. And Maria or Dorothy, are you going to put up the different policies, or do you want me just to run through them? Or do you have a list of them?
Martina, do you want me to share?
Or do you want to put the ones?
I think you can just probably run through them, Dr. Lane. There's a lot of them. So this is a consent
Okay.
item.
So we have one on the EMR, the medical record in-basket handling. We have a new policy. This has been a huge problem for physicians where patients contact the physician, send stuff to their in-basket, and the physicians are not having time to respond to it all. So now we have a new policy that's going to allow RNs to start handling the in-basket. They'll involve the physician when need be, but many of the times the RN can handle the request and take care of it.
Can I just ask a question? On the agenda, you're going through them, but it's not in the same listing as we have. So you have a new policy, but we had privilege forms that began first. Do you have those, Dr. Lane?
I have all of it, but I'm not sure the order that do you have privilege forms with changes? Is that the first thing you're seeing?
That's correct.
Okay, so I can do it that way. So the privilege form with changes were for family medicine, internal medicine, and NPs and PAs. And this was specifically regarding cardiac stress tests, on what training you need to do it and who will be available to give these stress tests. The one on neurology privilege form, this is on the use of Botox, and it's a better definition for the use, and specifically used for migraines or blepharospasm, which is spasm of the eyelids. The next is new policy approval. So stroke alert in emergency department patients. We have a stroke alert that this is what we are currently doing. So patients who come in presenting with potential stroke symptoms for under 24 hours, we jump into our stroke protocol. And this is really helpful. It coordinates emergency medical services, radiology, registration, nursing, MDs. And so it gets everybody going the same direction. The next one is management of patients at risk for depression, self-harm, and or suicide. This one's it has combined 6 previous policies, and there's really nothing new in it, but now it's more concise, and instead of having everything directed across 6, we've made it more concise. Next one, we now have a policy on nurses doing refills. And then I already mentioned the next one is the in-basket management. And let's see. And then Dorothy, correct me if I'm wrong, but is the pre-surgery clinic, is that the one that you said is going to undergo further changes and not be?
Yeah, so we've identified it does need additional revisions. So we humbly ask that if we could please, pull that from the agenda so we can make the revisions, and then we'll re-present it back to our committee. That is correct. That is the pre-surgery clinic RN process policy.
And this one's going to be really helpful so that our patients who are undergoing surgeries are going to go through a standardized pre-surgical screening. What used to occur is each individual physician would screen their own patients, and now we have input from Lombard, Dr. Voss from anesthesia, and Dodd. So we're going to have a very concise but uniform process on how to pre-screen surgical patients, but I'm going to have to bring that back to you when we have a more final one. Next is neurotrauma transfers. This is what we are already doing, but it standardizes which neurotrauma patients we are transferring, and specifically who we cannot keep. And then the next one is trauma surgeon, ED responsible, and it says ED responsibilities. I think it's supposed to be EP for emergency physician responsibilities in the emergency department. And this is how each of the 2 physician leaders' responsibilities when we're taking care of trauma. Next, we have annual policy approvals. There's no changes in the hospice policy and procedures and home health policy. And then the policy policy procedure, structural and approval. I think this is on the policy to make policies, and it's adding a risk statement to it. And then the last one is the quality assessment, performance improvement. There's minimal change, but they did add a zero harm statement under priorities. And so, and just to reiterate what Alice said, these have all been written up by small groups, gone over multiple times, then presented at the department level, and then finally at MEC, and now we're bringing it on to you. Any comments or questions?
No, thank you.
It's a lot to digest, and we're grateful that it does have to go through so many layers to ensure that our patients are safe when we practice these. Can I have a motion then to, if there's no audience comments, are there any comments from our audience regarding the medical staff?
Can the
consent?
motion be to accept, well, do whatever you want for
Yes.
the motion, but can you exclude the
Yes.
pre-surgical one?
Absolutely. So if
Yeah,
there's
I'll move
no,
approval of the consent calendar with the exception of pre-screening for surgery.
okay.
Can I get the motion?
Okay, so it's been moved by Director Shamlin, second by Director Brown, to accept the medical staff, I'm sorry, the Medical Executive Committee meeting consent agenda with the elimination of standard procedure pre-surgical clinic RN process. A roll call vote.
Director McGarry,
Aye.
Director Shamblin,
Aye.
Director Brown,
Aye.
Director Wong.
Aye. So the consent agenda has been approved with that one elimination. Then we'll move on to item 14, the consent calendar. And this is routinely just reports by our the chiefs, and again, aren't usually controversial, but there is the opportunity for anyone to pull in and have any questions that they might have for any of our reports or minutes. So do I have any board member who'd like to pull an item?
No.
If we pull anything, it will go under item 18, so it'll be later in the meeting that we would discuss it. Anybody from our audience that would like to pull something from our consent calendar? Okay. Seeing no hands, hearing no voices, can I have a motion to accept the consent calendar as presented?
I'll move to approve. Michael?
A second?
I'll second it.
Okay, so it's moved by Director McGarry, second by Director Brown to accept the consent calendar. Roll call vote.
Director McGarry,
Aye.
Director Shamblin,
Aye.
Director Brown,
Aye.
Director Wong.
Aye. So the consent calendar is approved as presented. Moving on to item 15, these are items that are here for discussion, not necessarily a motion. So in 15.1, we're going to have a report on the Patient Family Advisory Council. It's their annual report, and how fortunate we have Kevin Warren, who is going to be giving that to us. So you have the floor, Kevin.
Hi, I actually will be giving the report. This is Lorna Tierman,
Oh,
and that's okay. Kevin is here. He's on the board quality committee, and so he's here to answer any questions or chime in if I leave anything out. I'm going to share my screen with all of you, and just bear with me as I bring up the Patient and Family Advisory update. And so I will move to our first slide. We do not meet in July or August, so this report is from September 2020 to August 2021. Accomplishments that our PFAC was able to do. We meet monthly. There's 11 members. They helped us through navigating COVID and continuing to provide family-centered care, which was a challenge, but luckily we have opened that up a little bit more to keep our patients and families safe, but also allow for patient-family centered care. We had updates by our Director of Hospice and Home Health in our thrift stores, and PFAC, as always, gives input on what their thoughts are for those services. We had an update on our patient safety initiatives, and PFAC was able to give some input to our peer support program. And some of the members of our Patient Family Advisory Council are business owners in the area and are curious on how to launch peer support for their employees. They were very impressed with what we do to support our employees through difficult challenges. Our multi-specialty clinics and diagnostic imaging leadership provided updates throughout the year on available services and specialties and how we played catch up after being closed for some elective services throughout the year. Continued accomplishments. The PFAC was very passionate about providing input to our behavioral health leadership regarding creating a flyer with information on how to access mental health resources. We're continuing to work on that next year as it's a growing program, working with Eileen Knudsen and her team to make sure that the community has all the information they need to quickly access mental health resources. Our infection prevention RN, Svieta, gave updates on COVID vaccines and answered questions about community vaccinations when that was a concern for our community. And our wellness and community health directors provided us with a great presentation on our population health and community wellness services. And our PFAC gave them input on how to market these services so the community is aware of all the great programs that are available. We also then at our last meeting in June reviewed our accomplishments. And finally, we talked about what we want to work on as we reconvene in September. So continuing to receive key updates from key departments and have the PFAC offer their input. Review some complaints and get feedback from the PFAC on how they would provide service recovery to these patients with specific or trends and complaints. Focusing always on improving our patients' experiences and plan on hopefully attending our annual PFAC meeting. We were able to send 3 members last year because it was virtual. I haven't heard yet whether it will be virtual, but I plan on sending 3 members to that annual meeting. And as you know, we have 3 PFAC members that participate on one on board quality committee. That's Kevin Ward. Our cancer committee's Patty Johnson, and our medical staff quality committee is Alan Kern. Kevin also, I want to give him credit. He really helps me with our service recovery program data. So I couldn't do that without him. Continuing to focus on our PFAC volunteers. If you know anybody that wants to serve, have them reach out to me. We did lose 1 member this year, but we still have 11 members. Any questions or comments? And Kevin, feel free to chime in if I left anything out or ask questions of myself or Kevin.
Lorna,
Great. Sounds great.
Lorna, this is Mary. I just have a comment that, you know, I'm aware of how much we learn from the members of the PFAC Council, but it's interesting to hear that they're learning from us in return with around things like peer support. So it's nice to know that's a two-way street.
Definitely, yeah.
Lorna, Dale here. How often do you lose or gain members? I'm just curious how fresh the information is we're getting from the community.
Interesting. So our longest serving member is Doug Wright, and he joined in 2015 when we began. And our newest member is Kathy Hansen, and she joined in April of 2021. Yeah, so we do have, and then Alan Kern joined in 2020. Violet Nakayama joined in 2019. So every year it looks like we bring on 1 or 2 members, but always looking for increased community, membership. They just need to reach out to me. There's a vetting process where they meet with me, and they also meet with a couple PFAC members just to make sure that they understand what the commitment is, what we do, and make sure it's the right fit.
And how do you advertise for members if you do?
I do. I have cards in every clinic that describe their small cards that describe who we are, what we do, and to reach out to me directly if they're interested. I mean, I can always continue to do more marketing for members. Sometimes when people reach out to us to give us feedback, if we think they're a good fit, we will offer that they could serve on our committee. So we take them anyway, they come to us. So if you know any community members that are very interested, let me know and we'll start the screening process.
So Lorna, how large of a group would you be interested in having though?
I mean, many PFACs are large. I'm fine with having more members. I'd say maybe 20 would be a little cumbersome, but the more members we have, I think we spoke about it in our board quality meeting, the more we can have people on other committees, and that would be great. So it's not like I turn anyone away that we have a maximum number.
Mm-hmm. Any other questions from our audience for either Lorna or Kevin regarding our PFAC? Okay. Well, thanks Lorna and Warren for the report. And we look forward to hearing about those who go to the conference and what they're going to bring back.
Yes, thank you. We do too. Thanks so much.
Moving on to 15.2, the medical office building renovation project. And we have our Chief Operating Officer, Judy Newland, going to speak on that. I think Dylan's still on vacation.
He is not here this evening, so thank you, Director Wong. So this is an informational presentation. Just a reminder to you all, so every fiscal year, which you did this fiscal year, you approve the budget for the district, and in that budget is capital projects in which you approve a set amount for those projects. When we find that we may go over, if we go over a project amount, we do come back to the board and ask for approval. So this is just preliminary information, as I believe we're going to find we may be, because of some changes in our economy, that we are finding that one of our projects is going to come over budget. So the second floor medical office building is what we've noticed in the last 120 days. We've actually seen a 20% increase in costs, which I think for all of us is pretty amazing. And this is really attributed to about 3 different factors. One is that so many of construction was on hold for such a long time, and both in the public and private sector section. Now they all are kicking off. And so we are seeing that a lot of people are approaching construction. And so what is that causing? Procurement issues, ability to get equipment, supplies. We are seeing those are escalating. We know that even internationally, it's hard to get some supplies. Along with that, we are seeing some labor shortages, which are increasing cost. So really what we're here today to do is just to educate you and let you know that for this project, we do know that it is going to go over the $7 million. When we have the amount, we know we will come back to you for authorization, but I just wanted to educate you to what we're seeing in the industry and prepare you for that future request. Any questions?
Judy, you said it's amazing, but having been in the construction industry for many years, I can tell you it's not amazing to me. I hear it from private home construction and other commercial work that's being done. So it is a sign of the times.
I will say we have looked, Dylan is not here. He has looked at where we can trim costs back. So we are continuing to look at that, but this is an essential project. This is our future rural health clinic, primary care, behavioral health. We have a lot of providers we're going to put in there. So it's really important that we continue to be able to meet the scope of the project.
So Judy, this is Mary. Did we, I understand as Dale was saying that, this is an epidemic of sorts, but I wonder if we have learned anything about our cost analysis and our cost projections as a result of this.
Yeah, well, I will tell you, I think this is in the last 10 years, this is only the second time we've come to you. So I think in general, previously, we've done a really good job with that. With the pandemic and what's happened in this summer, and again, just the challenges the whole nation has had regarding supplies and being able to, the shortages, it's impacted us. But I do agree, Director Brown, we always want to make sure that we evaluate our process so that we don't come back to the board and ask for an increase in what was budgeted for.
Thank you, Judy.
You're welcome. Thank you.
Any questions from our audience for Judy regarding the medical office building renovation project and the cost? Okay. Hearing none, we'll move on to, thank you very much, Judy, for that. And yeah, we never like to see or hear increase in costs, but we understand that. We have board education, and we've got the topic of physician burnout, and Sam Smith is going to address that. And Sam, I can't remember if you're an APP, right? Advanced practice provider.
Yes, I'm here. Yeah, you can say advanced practice provider. I go by PA.
Okay.
Thank you. So my name is Sam Smith. I'm a primary care PA, and I chair the Joy in Medicine Committee. And I'm here to present on behalf of the Joy in Medicine Committee, which is a provider committee to address burnout. And I'm going to share my screen here. I can pull up the PowerPoint. Okay, hopefully you all can see that. Can you see the PowerPoint?
Yes.
Yes.
Okay, perfect. So our committee was formed at the request of MEC last year, and we really want to focus on building a lasting culture here at Tahoe Forest that supports physician and APP well-being and really demonstrates our commitment to preventing and addressing burnout for providers. I'm sure most of you have heard this is a big issue of national concern, and we want to do our best to try to address it here. Last year, we committed in a pilot program with the Mayo Clinic Wellbeing Index. So when you see WBI, that's the Wellbeing Index. And what that is it's a validated tool to measure burnout for, there's a physician tool and a separate PA-NP tool. They do also offer this for nursing, but we're not currently utilizing that function here at Tahoe Forest. So we did an initial assessment. It's essentially a few closed-ended questions, and then we were able to choose some open-ended questions, and I'll share what those are in a couple of minutes. But it allows us to measure specifically and directly our burnout rates, and we can break it down by provider type, by physicians, PAs, NPs. So we were able to get a lot of really meaningful data from this. We actually had very high participation rates. What I'm showing you is data from the November 2020 to January 21 assessment period. We are going to be doing a reassessment in the next couple of weeks with an update to our open-ended questions. The closed-ended questions will stay the same so that we can measure progress over time. So we had 52% of physicians participate, and that's 45 out of 87 active medical staff physicians at the time. And then 24 out of 25 of our PAs and nurse practitioners participated. So here are some of the high distress scores. These are broken down by types of activities that our physicians participate in, and that piece is not quite as meaningful as looking at our overall high distress scores. So high distress scores are associated with much higher risks of medical error, suicidal risk, severe fatigue, burnout, poor quality of life, change in jobs, change in setting. So these are very high risk physicians. So you can see here at Tahoe Forest, as of January, 37.5% of our physicians have high distress scores. The national average is 40.58. So we are slightly lower than the national average, but I want to point out that the national average is not a good score. That is not a benchmark that we want to measure against. Sometimes when I do this presentation, I compare this to average BMI or obesity rates. So that's not an optimal goal for us to measure against. We want lower high distress scores. We are able to break down the high distress scores for physicians by specialties. And what we can see is that the higher risk physicians tend to be in hospital-based specialties like diagnostic imaging, hospitalists, and then also primary care, which includes pediatrics, family medicine, and internal medicine. Our surgical subspecialties, including anesthesia and emergency medicine, had lower high distress scores. I wanted to share with you some of the answers to our open-ended questions. So these are questions that we were able to choose, and we will be choosing different ones for the reassessment. So we asked our physicians, what are the top 2 things that contribute to meaning and joy in your work? And the overwhelming majority was patient care and working with our colleagues. The top 2 things that make things difficult at work for our physicians, the number 1 issue across the board is our electronic health record. And, this can be broken down into a lot more detail, and we'll get into this a little bit later in the presentation. Mostly what our physicians are saying is we want to see our patients, we want to spend more time with patients, but we're spending a lot of time trying to do inbox work or answer emails or participate in meetings, charting. I actually looked at some of these answers yesterday just to see if there's anything new that's popped up over the last few months, because we encourage our providers to continue to reassess over time. You can do it as often as every 2 weeks. And I'm starting to see more answers pertaining to physicians feeling isolated because of COVID-19, like not being able to participate in face-to-face meetings. So that's definitely concerning. And I think we're going to start to see that more. People are also talking about feeling like there's lack of a common goal with their staff, with their coworkers, with administration. So that will be interesting to look at as well. We then asked the physicians, what can we do in leadership to help improve your well-being? So there have been asks for improving EMR efficiency and workflows, more support staff, nursing, scribes, less participation in meetings and administrative time. And we are seeing a lot of gratitude from our physicians for the physician engagement bonus. So recently, physicians are now able to be compensated for their participation in meetings, and that has been very, very meaningful for our physicians because they feel that often the meetings put them over the top for stress levels. When we look at our PAs and nurse practitioners in the health system, we have higher rates of high distress scores compared to physicians and compared to the national average. For APPs, the outcomes from high distress rates are related to quality of life, burnout, and a much higher risk of leaving the current job. I think that's because there's more flexibility in our profession to leave jobs versus physicians, and higher rates of medical errors as well. So we really want to address our high distress scores here. Again, we see when we ask our PAs and nurse practitioners what contributes to meaning and joy in your work, the overwhelming majority is patient care. One area that's very different from our physician colleagues is that the PAs and nurse practitioners really value positive feedback, being challenged, and learning. And so this is something that we should look at as an institution, really trying to foster. Things that make it difficult for our PAs and nurse practitioners. Again, you see the EMRN here, you see inbox management, but this is where we really start to see our PAs and NPs complain about not feeling recognized or heard or valued. And it looks like a mix of management, close local management and upper leadership. And, I pulled some quotes on here. Some people feel like treated differently than physicians, or maybe not feeling like they're kept in the loop. What could leadership do for our PAs and NPs? So listen to suggestions, collaborate, appreciate and respect the PAs and nurse practitioners, really support and acknowledge home stresses. We saw a lot of stress related to childcare and scheduling that had to do with COVID-19, more amongst the PAs and NPs than for physicians. And then help with the inbox again. Our PAs and NPs really feel like they need to feel heard and respected and appreciated. There is some data nationally, and I think there's going to be a lot more in the next year on evidence-based interventions that really work to address burnout. So professional coaching, workflow interventions, small group discussions, reflection. But when you look at all of the data, and this is not going to be a surprise, what works is a combination of addressing individual burnout and organizational change. So it's those two things together. So we can't just ask our providers to address their individual stress without making organizational change. And likewise, we can't make systemic change without asking our providers to look inward and seek help when they need it. So what have we done with this information since we got it in January? We've had a lot of regular communication with MEC. We did a recent presentation to Admin Council, and we've had a strong commitment from leadership to addressing provider well-being. So some of the things that have happened more recently over the last few months, earlier in the year, we had a commitment from leadership to pay for and enroll in collaboration with the Nevada Physician Wellness Coalition. So this is a program locally here that provides a speaker series and also small group workshops specifically addressing burnout for physicians and APPs. We've seen good participation in those, and our physicians are very appreciative of the physician engagement bonus because it feels like it allows them to participate and be reimbursed. The administration, and I want to express my gratitude, and this is on behalf of the Joy in Medicine Committee, recently recontracted with the Mayo Wellbeing Index for an additional 3 years. This is really fantastic and makes us feel very supported, and also enables us to continue to capture data over the next 3 years. We also, as a committee, asked for an extension of the Wellness Bank funds to help cover counseling in addition to current resources for counseling for our providers through employee assistance programs and also through medical staff. And they acted very rapidly and extended this not only to our medical staff, but to all employees to allow us to use our Wellness Bank to cover counseling. We have also asked for more support staff, and we're seeing good support from administration to hire, for example, more nurses in the outpatient clinics. And I believe you heard earlier in this meeting about nursing protocols to help support providers with things like refill policies. There has also been a lot more collaboration and communication with leadership over the last month or two, and we're really looking forward to some plans that they're working on to address our recommendations that are more specific coming from the Joy in Medicine Committee. So what is next? We have an upcoming reassessment period for our medical staff in the next few weeks. We have some new open-ended questions, really addressing what resources have people used in the last few years? What barriers are people finding when they want to address their well-being? What gaps are there and where can we help fill in the gap? And what additional systematic changes could we do that might be beneficial to address well-being for providers? Again, we're going to continue collaboration with leadership. The medical staff will be updated on the data and the action plan that is being developed in collaboration with the Joy in Medicine Committee and leadership, really starting to look at some ideas for how we can optimize EHR, and look forward to hearing more about that. continued participation in the Wellbeing Index, continued participation in the Nevada Physician Wellness Coalition Speaker Series. And then we would like to continue to recommend the physician engagement bonus for meetings and participation in the workshops, as it really encourages our physicians to participate. And then I just have this last slide on here, just sharing our goals with this committee and feeling like leadership is aligned with this committee in our goal to really address burnout. And I am happy to answer any questions you all have.
Thank you so much, Sam, for your presentation. Joy in the workplace has been a very hot subject with our board, and we've been asking for a while to hear from your committee, because certainly how our providers are feeling really makes a difference in the care that our patients get. So thank you, and I am pleased to hear that we are working collaboratively with the physicians, NPs, PAs, all those who provide care to our patients to lift you up and give you a little bit more joy in the workplace. And it's also things that we're doing for all of our employees. It is a trying time. We have been through so much with COVID, just with the need for access to providers, trying to get more providers on board, getting people oriented. All of those things have been stressful. And they continue to be stressful, but how can we support one another through this so that our patients get the quality of care that we say that we give? So do we have any other comments or questions from our board regarding burnout of the physicians or joy in the workplace?
Yeah, Alice, I'd like to echo what you were saying about how much we've looked forward to this presentation. We've heard about the work of the Joy in Medicine Committee for quite some time, and have really, as I look forward to this. I've heard a lot of discussion around physician and APP relationships with leadership and administration and what have you, but I'm curious as to the peer support and how that works within the various professions. I would assume that it's quite an active interface that goes on.
So I'd love to jump in here because I think I know a little bit more about the peer support program that we have. As you guys have heard over the last few years, we have participated in the Beta Heart program through our malpractice insurance carrier. Part of the Beta Heart is the care for the caregiver. Interestingly, we have had a care for the caregiver policy for physicians and APPs much longer than we've been part of the Beta Heart program. And we actually took that care for the caregiver policy from the physicians and APPs and kind of rolled that out to the rest of the medical staff during the Beta Heart program. So we've actually had a pretty robust program, and there's a big process behind it. But basically, anytime there's a code or a traumatic experience, I am notified from the through some processes through nursing supervisors and some of Karen Buffone's team that reports out the codes to me. I then make sure somebody is reaching out to the provider and then offering well-being resources. We have a flyer that Dorothy Piper has put together with those resources. And I not only reach out for those unexpected outcomes or code situations, but even things that can be stressful. For instance, this weekend, I reached out for support regarding our new California mandated policy on COVID vaccinations, as that can be very distressing for physicians, APPs, employees, staff, et cetera. So, and again, referred all of those resources and re-explained all of the counseling resources that were available for that. I did want to point out a few things. Sam, you did a fabulous job with your presentation, and thank you so much. I wanted to point out a few things that I thought were really pertinent in her presentation. One is that, as you may have noticed, that one of the two things that was the most important to the physicians was their colleagues and interacting with their colleagues. Prior to COVID-19 and kind of Zoom meetings like this, we got to chat with each other before meetings, after meetings. We used to do that at the board meeting. We'd be like, hey, Mary, how are your grandkids? Tell me what they're doing, and be able to actually have that social interaction with each other before and after the meetings. And I think that when Sam mentioned that, you know, one of the stressful things that she's seeing in these surveys that are continuing to come through is that lack of interaction with each other. And so the question is, how can we get back to something like that? You know, we have in the past had big social events for our medical staff, and maybe we need to be having small group social events that we can be COVID compliant, but can still maybe have some of that interaction. I did want to explain this physician engagement bonus that she pointed out. So the premise behind this is what we know about process improvement and buy-in and change throughout the hospital is if you can get all your players at the table collaborating together, figuratively at the table, on the Zoom meeting together, and collaborating about certain issues, then you can move process improvement through faster, better with that engagement. And so what was happening was the physicians were having to get up early and come in and participate in a meeting for an hour or two beforehand, where everybody in the meeting were staff members. So they were on the clock for time, and everybody was getting paid at the meeting except for the physicians. So it was pulling them away from family time, or it was taking up their lunch hour, or pulling them away from the yoga class they normally go to. And they were getting burnout from that. And so this engagement bonus, what basically allows us to have them participate for a certain amount of hours per fiscal year in order to get that engagement. And my understanding from Karen Buffone and her nursing team and all of our other teams, the engagement and participation that we've been able to get from our physicians and our APPs in this has been dramatically improved with that. So I just wanted to kind of get that information back. I also wanted to bring up, you know, she mentioned in the evidence-based things that workflow intervention is something that has been proven to improve the joy that people have and reduce the burnout. And I wanted to thank Jake Dorst and his team. We are engaging and have been discussing with consulting firms to come in and really help the physicians and APPs to improve their workflow within the EHR, because we know that that is something that can help to decrease the amount of time that they're in front of the computer and hopefully increase the amount of time that they're able to be with our patients. And all of this stuff will be, you know, we're currently starting to communicate this all out to the medical staff. And so you'll see more of that happening along the way. So again, thank you, Sam, so much. We truly value you and the entire Korean medicine team.
Okay.
Yeah.
Thank you so much, Heidi. Okay.
Director Shamlin, you have a comment or question?
Yes, Sam or Shani, I want to focus a little more on that EHR. You know, change is a stressor in any profession. And I can remember when 8 years ago when we switched into CPSI, the revenue cycle, people were pulling their hair out and going through sleepless nights. And then, of course, more recently with Epic. But over time, you know, as you learn these new processes and procedures, they seem to ease. Do you see a trend line that says people are getting more comfortable with EHR, or has it peaked in its level, or what's going on? What's the trend?
So Dale, I'm going to jump in here. So I kind of equate the EHR having kind of three phases. You can, it's similar to using an iPhone. So you have my 83-year-old mother who uses an iPhone in a certain way. You have myself who uses an iPhone better than my 83-year-old mother. And then you have my teenagers who use an iPhone way better than I do. So our medical staff is on that spectrum between the teenager and my 83-year-old mother. And what we'd like to do is take them from wherever they're at and try and get them all to be like my teenager on the iPhone. And so that's what this EHR optimization will be doing. And, you know, a lot of what I did to optimize my workflow, I did within the first few months of us implementing it back in November of 2017, because I haven't been forced to sit down and improve it. Sam can tell you a story about how she spent a day with one of the EHR specialists and completely revamped how she worked and improved it. Sam, do you want to jump in?
Yeah, I would agree with that. And I also think, you know, one of the things that we're seeing from our providers, I apologize, they're vacuuming right outside my door, is that our patients have, or at least from the provider perspective, a lot of access to us that they didn't have several years ago. So they are able to MyChart us, they are able to call, their labs come through, their pathology comes through on top of the charting. And so a lot of it is the workflow in the EHR, but the other piece of it is simply just the work of it and feeling like patients have access to our attention 24/7, because you might go in a room and spend 30 to 40 minutes with a patient who really needs help and then come out and answer 5 MyChart messages from patients. And that's where the support staff, I think, really comes to play, because the nursing protocols, when they're able to do refills that are based on a protocol or answer some messages or take some of that burden off, I think is going to be really helpful in addressing burnout, in addition to some of the workflow things that Dr. Cole's talking about.
And Scott Baker, along with Alex, are working on hiring 5 new registered nurses for exactly what Sam has talked about. And that's what those nursing protocols that you guys approved today will be helping to improve that workflow.
Okay.
We have any other comments or questions?
Director Wong, this is Harry. We really appreciate Sam's input and leadership and the other medical staff members on this Joy of Medicine effort. And we're looking at this as a health system comprehensively. So we've even devoted 3 administrative council persons on this, Shani, myself, and Alex McLennan. And, you know, so we're sensitive to all of our team members and looking at trying to discover the best information about how to identify it, and then how to have multiple paths, hopefully, for recovery as well. It is a national phenomena. And so it is, Shani and our team have put together a pretty long list of action items, many of which are underway, but it's a very challenging journey that we're committed to as we work to support our team, which is out there focused on our community full-time as well.
Thank you.
Director
Judy?
Wong, I just want to make one comment, because Sam actually brought it up, and I'm sure the board of directors are not aware. But actually, during the pandemic, I want you all to know that the APPs really staffed the respiratory illness clinic. They were there every day. And sometimes more than one came, and they made such a difference. And there were some physicians that also were there, but the APPs were there every day. They started day 1 and they ended there. And I really want to thank all of them. Sam was there herself for all that work. So very much appreciative.
Thank you so much. And I just want to reiterate what Judy said. I know one of the NPs spoke to me about the respiratory clinic, and she loved working there. She felt it was so collaborative. She thought that everybody pulled their weight in it, and that everybody was there for the best of the patients. So the working of collaboration was really key to her, and I think that came out in your presentation as well, Sam. I'm looking forward to hearing in the future how this program is going, and we do want to have you or members of your committee come back and let us know what the new assessment shows, what things have been really helpful and what other things still are being worked on. So thank you, and thank you, Dr. Cole, for working on the joy of medicine again. Thank you. We'll turn on now to 15.4, which has been a disruptor to the joy of the workplace, but Judy Newland, our COO, is going to give us an update on COVID-19.
Thank you, Director Wong, and I'm going to let Harry start.
Yes, good evening, Chair and members of the board. I'm really pleased to share, as we look at rural counties, public health is really difficult to really put quality, timely boots on the ground. And so we have really committed to our communities that we're really there for them from a public health perspective and a healthcare perspective. And our team really has been courageous about that, even though it's very tiring, very stressful for over 18 months. It's cost millions of dollars to do to date, but it is probably one of the most important public health efforts hopefully we'll face in 100 years. I hope these don't come around more often than 100 years. And I wanted to give a little bit of our local picture and then talk a little bit about nationally and worldwide. And I think you're going to hear some encouraging nuggets here. But just to paint a picture a little bit locally, 4 weeks ago, we had 20 new positive lab tests within our 3-county area of Eastern Nevada, Eastern Placer, and Western Washoe County. 1 week later, 3 weeks out, it was 50. And then 2 weeks out, it was 70. And last Friday, it was 91. And as of today, we're at 63. I've been doing these Friday to Friday. So there is some hint as we look at graphical trends that hopefully late last week or so might be a current peak. So even though you're reading in the news that inpatient hospital stays are up, which is true, we have in Nevada County, for example, between 25 and 30 inpatients. We're fortunate in the eastern counties and Western Washoe that we have 5 inpatients here, and let's say around 25 in the West, because of this tremendous public health effort that our team has been about, which involved testing. It involved our registered nurse hotline, treatment, and vaccinations. I think it's put us in a much better state. The thing to me that's really encouraging as I look worldwide, and I'm going to bring it down to California. If you look at this pandemic over the last 18 months, and this pandemic is going to continue for an unknown duration. So our comments to our team is let's take this one day at a time. We can achieve anything one day at a time. We're not in control of tomorrow, and all we can do is let's handle today. But what's encouraging to me is that even though the peaks are about 4 months apart over the past 18 months, the recent peaks worldwide are about 40% lower than more distant in time peaks. So I think that's remarkable. And then the valleys will hit about 2.5 months after the peak. If we come to the US and then to the United States or to California, what we see is that the peaks are much more spread out. They're not every 4 months. So the US has been doing a much better job than the worldwide situation. The other trend that's really positive is the peaks are about 300% lower now than they were in a more distant point in time. So they're 3 to 4 times lower than they were before. And that's true for the US and for California. So we've really narrowed the focus on those that are ill. Yes, the numbers of hospitalizations is up right now, but what I do like seeing is that we were seeing positive lab tests grow over a 4-week period, and we're hopeful that we'll now start to see a 2 to 3 month downtrend there. With more than 450 inpatients that we've tested for known or rule out COVID, we've had only 4 deaths to date, and our team has done an amazing job. Every life is super special and precious, but I think this is really one of the best outcomes that I would say for any team that I've observed out there. So I just wanted to give you that little bit of a global and local sketch, and Judy has a lot more important data to share.
Thank you, Harry. And I just wanted to remind the board, one of our goals during this whole pandemic is, again, to make sure we provide a safe environment for our patients, for our visitors, and for our staff. And so we continue, as you all know, through this whole pandemic, continue to make sure that our employees are masked, washing hands, etc. So just an update on the current activity for our health system. And I think you are all aware that the state of California gave all hospitals some mandates that we needed to implement, some within 5 days, others we got about 10 days. So we have been very busy to implement those mandates. I'll begin with talking about the mandate of employee testing. So the mandate required that all employees, either both in the clinical and non-clinical areas, be tested for COVID, depending on your per week. So depending on your location, either you are tested twice a week. So anybody in the hospital is tested twice a week. It doesn't matter what your job is, you are tested twice a week. If you are in the offsite clinics or other offsite buildings, you must test once a week. So that began on August 9th, and we're required to have full implementation this week, Monday, August 23rd. So we are providing testing to all of our employees that are unvaccinated or only partially vaccinated. And that is available 6:30 to 8:30 Monday through Friday. The goal is that employees can, before they start work, they can get tested. Currently, I believe we are testing approximately, we have about 160 employees or so that we are testing and monitoring. And again, those are the ones that are either unvaccinated or only partially vaccinated. Regarding employee vaccination, so along with that mandate is the requirement that all employees be vaccinated either with the 1 dose of J&J or the 2nd dose of Moderna and Pfizer by September 30th. And so there are 2 exemptions to that. There is a medically qualified exemption or religious exemption. And I don't have those memorized off the top of my head. Our occupational health department and our human resources are monitoring that. Though I do want you to know if you do have an exemption, you have to continue with your testing. So currently in our workforce, we have 85% of our staff and are vaccinated, and we currently have approximately 4% who are in process. So our staff does know that if you're going to do the Moderna, you need to have your first dose by September 2nd. If you're going to do Pfizer, you need to have your first dose by September 9th, and then J&J by September 30th in order to be compliant with the mandate. One of the things we are doing is we are trying to help any employee, depending on what they would like to be vaccinated with, help them find a location for that vaccine. So we want to be really supportive of the staff. The other mandate that occurred is the visitor policy. So on August 9th, the state of California required that anybody who wants to visit a patient in the hospital must either show that they have been vaccinated or show that they have been tested with a negative test within 72 hours of visiting. So we did put that in place on the 9th, and I will tell you, actually, the community has been great. We did communicate that out via social media, and we really have run into limited issues on that. People come with their card, or we're helping them locate that. And we do have some people come with their testing. So appreciate all the staff that have absolutely dived in to help meet those mandates. Just some other things that are going on, so you are aware. I think Harry already mentioned we have 5 patients in-house, but to be honest, we have a pretty full house. We may not have a lot of COVID patients, but we actually have been very busy. We are fortunate that we've had anywhere from 1 to 5 this August, and as Harry mentioned, Sierra Nevada Hospital in Grass Valley, I think, had 28 COVID positive today, so we feel very fortunate. Our partners to the east of us, Reno, have also been very busy. So they are seeing quite a bit of COVID inpatients, along with just a lot of patients. So transferring patients is, again, challenging. We've been able to really keep all of our patients. Incline Village Community Hospital has been able to transport patients to Tahoe Forest Hospital. We did have one incident. They wanted to transfer the patient to Reno. None of the hospitals could take it. They were completely full. They held that patient for about 16 hours, and then Tahoe Forest Hospital was able to accept them into the ICU. So our neighbors are also very busy with COVID positive patients. Along with that, we continue to monitor our supplies. It's very important. And so we are in good standing with our supplies. I think our only shortage is small gloves, and I did not check to see if they came in today. But I do want you to know, besides the pandemic, we have been very conscientious about the smoke and have been communicating to the staff that we really do have, all of our facilities have very, very high filter systems, our hospitals. And then again, HVAC in our offline areas. And people, what it does not do is get rid of smoke. It gets rid of the particulates, but the smoke is still there. So we have offered to any staff who want an N95 mask to please, their director can come and get them. And so we have distributed quite a few of those, and we're more than happy to continue to do that to support our staff. Along with that, I think that, again, we continue to work closely with both Placer County and Nevada County. We are still continuing to be fortunate to have our Optin Serve testing site in Truckee. They have expanded their hours again because they are seeing an increase in testing. And we are fortunate still to be able to provide 3 types of tests. We have our ID Now, which is for our symptomatic patients. We have our BioFire, again, which is COVID plus 21 other respiratory. And then we have our PCR sensitive test that allows us for COVID only. So we are very fortunate to be able to continue to provide that to the community. Before I open it up to the board for questions for my peers, is there anything that I've missed or anything that you would like to add regarding our response to the pandemic?
Judy, you did a fabulous job. Thank you very much for that clear and concise report.
So, Board of Directors, do you have any questions we can answer for you?
Judy, Dale here. At one point, you had insufficient data on whether or not some employees who you had listed as unvaccinated, whether they got their vaccinations elsewhere. Has that gap been filled in?
Yeah, so as part of the mandate, the first thing we had to do was to get clarification on every employee and physician, their vaccination status, and we have done that. So if we vaccinated here, we had that information. If not, we got from them, because if they didn't give it to us, they had to start this week their testing. So yes, we have closed that gap, which is part of the reason we're at 85%.
Okay, and then second question is, what about third vaccination for Pfizer or Moderna?
Yeah, so we are following the CDC guidelines regarding the third dose. It's actually the third dose for immunocompromised individuals in our community, and they can schedule themselves in my turn or walk in and go to our gateway clinic for vaccination if they meet that qualification. We just ask them to attest to that. They do not need to have a physician document on that.
Okay.
And let me clarify that. I'm sorry, Mary, one more thing.
That's okay.
For incline residents, currently Washoe County has given us direction that they will do the third dose for the residents of Incline and Crystal Bay. And we have sent that information out via my chart or website for that community.
Regardless of their health status?
No, they need to be immunocompromised. That is the CDC guideline.
Okay.
That's the only people that are getting a third dose.
Gotcha. Okay.
Do we anticipate that that's going to change around the 20th of September? I think that's the date that I've heard that it'll be available. The third dose will be available to the general public.
So that's correct. So we've read the same thing. We are anticipating the CDC to open up potentially September 20th. We are working on a plan on how we as a district are going to manage that volume. I do anticipate though that it will be segmented. So maybe it will be 60 and over to start with, or, you know, I'm not sure, but I'm going to guess that was some of the things I've read. But yeah, we are anticipating that and we're preparing, and we are actually talking to the counties about that also, because, you know, we've vaccinated a lot of people, thousands. So there's a lot of boosters that are coming, plus our own employees.
But and the third dose, go ahead, Mary.
Oh, I was going to change the subject, so go right ahead.
But the third dose will be also offered by the pharmacies.
Yes,
yes.
They currently are doing third dose. All the pharmacies in the state of California are doing third doses, and those in our community are also in our region. Thanks, that's a good question.
I was going to say,
change the subject.
Yeah, I'm thrilled to hear that we are lagging behind some of our neighbors and the like. I think that's great news, and I think testimonial to a lot of the work that we've done. But I'm also wondering if it has anything to do with the fact that our schools have not opened yet. And
so
hoping that we are gearing up for the fact that the schools are going to be opening next week.
Yes, Director Brown. So we have had that conversation. We do recognize that, especially nationally and on the east side, there seems to be a surge when the schools open. I do believe our schools are masking. I'm not sure that it happened when other school districts open. They are masking, but yes, we have had that discussion that next Wednesday, Thursday, Friday, potentially we will see a change, but we'll wait and see.
Great. Thank you, Judy.
Yeah.
Any comments from our other members of our board? Any comments or questions from our audience for Judy or Harry regarding COVID-19? Okay, thank you so much for your presentation. It's not exactly where we expected to be 6 months ago, but we're here and we're continuing to keep our residents safe as much as we can. So thank you again. Thanks, Harry. Item 16, and this is for board action. At our meeting last month, one of our directors, Art King, submitted his resignation as of August the 12th. So now we have to go through a process of replacing or filling that vacancy. And if our general counsel, David Ruderman, would let us know where we are and how we go with that process. And I think we need to have a motion on how we're going to pursue it. Correct?
Yes, thank you. I didn't know if Mr. Owens wanted to chime in first, if he had something. Otherwise, I'm happy to proceed.
David, proceed.
So as some of you are, actually perhaps all of you are aware, when there is a vacancy on the board, that gives the remaining directors a choice. you can either appoint a new board member, which has to happen within 60 days of the vacancy, or you can call a special election to fill that seat. And that would require the district to pay the associated costs of that special election, which, although I don't have the precise number, would not be insignificant. And in the past, the board has consistently opted to go the appointment route. For the particular seat that is now vacant, it's my understanding this Director King's seat he just had been elected last November, and therefore his resignation falls within the first 2 years of his term. So but still more than 130 days from the next general district election in November 2022, which means that the appointment the board would make, if it chose to make an appointment, that appointee would sit in Director King's chair essentially until November 2022 or December 2022. If that person wanted to then remain in that seat, that person would have to run for a 2-year term in November 2022, although the person wouldn't be obligated to do that. So this evening, the motion that would be appropriate would be one that would either decide to pursue the appointment process, in which case we can speak with Mr. Owens about the procedure for doing that. Normally we open it up to the public. We have to provide notice. We receive letters of intent from potential appointees. Then those are considered by the board for appointment. So a motion to either pursue appointments or a motion to pursue the special election. If that, I'd be happy to answer questions.
And then the alternate to that is if we don't do anything, then the county will select and appoint someone to fill that position.
That's correct. If the board takes no action after 60 days, then the Board of Supervisors of, I believe it is Placer County, because the majority of our territory lies within Placer County, the Board of Supervisors of Placer County could appoint someone who resides within the district.
You say could appoint or would appoint?
I mean, they are supposed to appoint.
But I will tell you, Director Chamblin, they could choose not to appoint and you would have a 4-member board until the election period.
Yeah.
Okay.
So any comments from our board as far as how you want to pursue the vacancy?
Just for clarification, David, Art had a 4-year seat, but this would only be to fill the first 2 of that.
That's right.
Okay.
So the way the statute is written, if the person resigns within the first 2 years, then they've got you can only fill it for that portion. If he were to, and then, if it was a resignation in his 3rd year, then it would be appointment for the remainder of the term, and then it would just go back to the normal. But they want to try to keep the staggered nature of the board
right
going forward.
And that's the same process that you went through, Michael, when you were.
I am familiar with it, yes.
Yeah.
Oh, okay. Yeah.
Okay.
And that I went through it as well. Well, I personally am in favor of an appointment for this last year, and I would recommend that we do fill the seat, advertise for candidates, select a candidate if we can come to an agreement, and make that appointment.
So did you have something to add?
Oh, yes.
Yes.
Sorry.
I didn't want to, that sounded like a motion, so I'll wait, Chair Wong, until after.
Oh, is that a motion?
No,
Yes.
another question for me. Are we already 14 days then already into the 60 days?
No, it started on the 12th. That was the beginning of the count.
Yeah, so that was 2 weeks ago today. So,
Yeah.
okay. So the clock's ticking.
Yes, exactly.
Yeah, 60 days.
Okay, so Ted has had his finger up for a while now.
Just a couple other points of clarification for anyone watching. Candidates must be registered voters within the district of the hospital. To be clear, that's correct, David?
That is correct. And there is a map of the district boundaries on the website under our transparency portal.
That's right. And the process that we would pursue, directors, would be we would post it in the same manner in which we post your public meetings and in prominent locations, and we will run it in the newspaper and other periodicals and social media. I think that we haven't settled on it, but I would recommend a 3-week period for letters of interest. We'll notify the public with our posts when that date ends, and then we will begin the vetting process with you.
Okay, so I've heard one director gave his opinion of what should happen. Do I have anybody that's in agreement or anybody opposed to that?
I agree with.
And that's not a motion, I'm just asking for opinions.
I straw vote is for the appointment.
You might want to get some public input if there is any before you make sort of a straw poll.
Right. So I'm just asking the board at this time for theirs. Okay, so Michael's shaking his head yes.
We agree. Yep.
Okay. Now can I have input from our audience in regards to filling the vacancy on the board of directors? Okay.
I see no hands.
Okay. Yeah, there's no comment from the audience. So can I have a motion on appointing?
A motion to pursue appointment for the board vacancy.
Okay. Can I have a motion to pursue a appointment for the board vacancy?
So moved.
Okay, so it's been moved by Director Brown and seconded by Director Shamlin. Can I have a roll call vote, please?
Director McGeary,
Aye.
Director Shamblin,
Aye.
Director Brown,
Aye.
Director Wong.
Aye. So the motion has passed that we will appoint. So if I could ask Ted Owens and Martina to make sure that we have all of our forms in place, our notices out, and our publication regarding applications or letters of intent.
We will be working side by side on that, Chair.
Okay. And then you'll let us know as far as a date when it'll all be available for a meeting of the board to vote on or to select.
And we would work that out with you as chair and agenda setting.
Okay.
I will pull you later this evening for dates at the end of the month. It looks like the 60-day cutoff is going to be October 11th. And I know that you already have a retreat scheduled, so we will work on the dates kind of around there.
Okay. Thank you so much, Martina, for noticing that. Okay, so 17, we didn't pull anything. Board committee reports. I know quality met.
Finance met.
Okay, finance met. So can we start with qualities report?
Yeah, absolutely. So on the board quality, met on August 17th. A couple items covered there. One was a PFAC update, similar to what we got today, so I won't go into that. An update on the Beta Heart program and continue to perform exceptionally well there, effectively meeting all of the metrics and maximizing the return from that program. There were no updates on the governance quality assessment and understanding that the work being done there is it takes time, right, to see progress there. The biggest part of the discussion was really around the CMS quality star rating, the 2-star rating there, and really digging deep into one, why that score is what it is, and two, efforts being made to understand it. As I said, I guess it was earlier in closed session, so I'll repeat it here. Number of items. One, we report on 18 of 40 total measures for the star rating. Incline actually doesn't have enough data to report at all. So while it is a very important metric and it's a very public metric, and the work to get it back up to at least 4-star is critical, it does almost seem as though the star rating is biased against systems like ours. The other thing I pointed out was data is from 2016 to 2019, so it's actually fairly old data. The output right now, the new processes are being put in play to identify complications and readmissions and the cause for that. And I think those are the key highlights from the meeting.
Thank you, Michael. Finance, Matt? Dale Shamlin?
Yes. Mary Brown and I, as Finance Committee, met with Crystal Betts and discussed the fiscal year end. We had a second look at some adjustments were made at that first look that the entire board looked at. But there are going to be relatively few adjustments to the finalization of the books for the fiscal year end, and it was a strong year. We also looked at the accounts receivable. That was one of the primary reasons we met, was to review accounts receivable. There's still a bit of a struggle going on there. But Mary, I think you'll agree that the trend line looks promising in getting a hold of that situation. So
yeah, I think it's great.
Yep. Okay. That's all we have.
Okay. So then we'll move on to 19. Any other reports that a board member has? No. And in final closing remarks, I'd like to wish Alex McLennan and our whole organization the best of luck tomorrow, because they're going to be doing Best Place to Work awards, and we are in line for Best Workplace of Large Employers. So fingers crossed, everybody.
Thank you.
All right.
And the other thing I'd like to say is that I've been working with Harry and meeting with various other board members from special districts, just to, again, strengthen our relationships with them, finding what our common ground is. And I think it's been very helpful, especially to me, to meet other board members and talking to them about what is it that we are doing for our residents. So thank you, Harry, for always inviting me to go to those, and also to Ted, who's tapped me on the shoulder and told me to come.
Thank you, Alice.
Happy to have you there.
If there's no other further comments, then I'm going to adjourn this meeting. Thanks, everybody, for your help.